All right, hello everyone, and welcome to the December 2021 edition of the Prehospital Care Research Forum Journal Club podcast, the last of the year. As always, the Prehospital Care Research Forum is dedicated to the promotion, education, and dissemination of prehospital research. And we believe it is the responsibility of emergency medical professionals worldwide to help build a body of evidence to examine prehospital emergency care. And here with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. And so I'm Remley Crow, and today I am joined by Dr. Tony Fernandez and Jeff Rollman, and it is my great pleasure to welcome some of the authors from this paper that we're reviewing, Dr. Matt Harris and Dr. Lauren Browne. As a reminder to everyone, the name of the article we're reviewing is Impact of Pre-Hospital Pain Management on Emergency Department Management of Injured Children. That is hot off the press, not even off the press, in pre-hospital emergency care. And as always, our discussion will be paired with a review article written by our very own Dr. Tony Fernandez in EMS World called Journal Watch. And so we encourage all of you to check out this article. It will be at emsworld.com under the category of education and training. And so thank all of you for joining us today. I want to remind our listeners in the audience that you can use that chat feature on your screen to type in questions and comments, and we'll be bringing your questions and comments into the conversation as we go. And so with that, let's kick off. First of all, I'd like to thank both of our authors for being here. So Dr. Harris, Dr. Browne, thank you for being here.
You're welcome.
Thanks for having us.
I think it would be great for our audience if we could kick off with just a couple of introductions. It would be great to hear who you are, what you do, and specifically how you got involved in the world of EMS research. So Dr. Harris, I'll start with you.
Great, thanks for having us. So my name is Matt Harris. I'm a pediatric emergency medicine attending at Cohen Children's Medical Center of Northwell Health in New York. I'm also an EMS physician and medical director with our EMS system here. And I'm a long-term recovering paramedic. I've been involved in EMS since 1998. I was a junior volunteer ambulance corps member, became an EMT and eventually a paramedic. And I've really dedicated the better part of my adult life towards understanding how we can take care of children in the pre-hospital setting and how that treatment impacts downstream care in the emergency departments. And I have to say that my research bug, if you will, came from going to the National Association of EMS Physicians Conference and just seeing just how much important research is out there, and seeing folks like Dr. Browne and Remley and others out there really publishing important work and wanting to be a part of it.
I also caught the bug at an EMS conference. It's funny you should say that. See how we get drawn into research. And Dr. Browne, would you mind telling us a little bit about you and your journey into EMS research?
Sure. So my name is Lauren Browne. I'm an associate professor of both emergency medicine and pediatrics at the Medical College of Wisconsin in Milwaukee, Wisconsin. By day, I am an emergency medicine provider at Children's Wisconsin. How I came into EMS and research, I guess taking care of children wasn't confusing and chaotic enough. So I decided to be a pediatric emergency physician, and that wasn't chaotic enough. And so I decided, you know what, let's take on the additional challenge of moving that medicine into the real world. And then when I've been in the capacity here, both as the EMS liaison for the hospital, as well as the pediatric medical director for our local EMS agency for about 8-9 years. When my predecessor left the institution to take a job opportunity elsewhere, I jumped at the chance to be involved. My emphasis is researching pain management in children in the EMS population, and it's just been wonderful to work with dedicated pre-hospital providers who clean our patients up very nicely and present them to us as typically nice packages. So I have a great deal of respect for the suboptimal environment in which pre-hospital providers practice excellent medicine. So it's been a wonderful opportunity.
Well, that's fantastic. We are so excited you are here, and particularly about this study. And this study was focused on pre-hospital analgesia, as it turns out, for pediatric patients. There's been a lot of work around analgesia in adults, so I was really happy when we came across this study that's looking at some of those challenges associated with the pediatric audience. I was wondering if we could talk just a little bit about, what question this study was trying to answer and what made you all decide to take this one on?
So Matt, do you mind if I take this one? So I will give you an honest answer. Several years ago, I submitted a grant application to the NIH to look at the barriers that EMS providers encounter during real-time care of children in pain. One of the critiques of the reviewers was, you don't even know if what EMS providers do changes what happens in the emergency department. And while I had very strong suspicions that it was true that EMS providers' decisions absolutely impacted the care of the child down in the emergency, down the course of their emergency care, they were right. There was nothing in the literature that showed, other than the fact that if you provided opioids in the pre-hospital setting, children received their opioids earlier in their care. There was really nothing that quantified the impact of pre-hospital decisions. So noticing that glaring hole in the literature, it was an easy lift to say, well, we need that data, those data.
Absolutely, and that's an interesting aspect, because it may be a little counterintuitive to think, well, if I give medicine in the pre-hospital setting, they're going to get more medicine quicker. I mean, it's 5 minutes away. What if I just roll to the ED doors? They'll get their medicine as soon as we cross that threshold, right?
I think that's a very intuitive way of thinking. And I think it's further impacted by the fact that the clinical time that EMS providers are face-to-face with their patients is relatively short. And so sometimes, I think frequently, in the pre-hospital setting, the providers, those professionals do not see the impact of what they do. Because if you give a dose of fentanyl to a child and drop them off, 4 or 5 minutes later, you may not have seen their pain change. And I think it was really important for us to try to, again, quantify this impact, to be able to make sure that we could, with strong data, show that this was important and it did change and impact in a positive way the care that children received.
And that might, dispel some of the mythology around pre-hospital pain management in children and some of the barriers that Lauren was alluding to.
Oh, we are definitely going to be digging into some of those barriers, because it's really important to see real world practice and those things that are making it difficult to assess and treat pain in the pre-hospital setting. I love that you mentioned the importance of linking pre-hospital to outcomes, because often, as a field EMT, for me, it was like taking a test but never knowing how you did, or like the master chef who creates a dish but never gets to taste it. So getting that feedback and knowing that what you did made a difference is all too important. And now, before we dive into the exciting results of this work, which is why I think most are here, we are going to talk a little bit about the methods. And before I turn it over to Dr. Fernandez, I'm probably going to steal a little bit of his thunder, because I have some experience working with this organization. And I think it's worth taking just a moment to talk a little bit about what Pitcairn is and its relationship to this study. So would one of you like to talk a little bit about what is Pitcairn and how did that fit into this study?
And so Pitcairn is a federally funded collection or network of emergency departments and EMS agencies that collaborate in pediatric emergency care. It's been continually funded through the federal government now for more than 20 years. And in its current configuration consists of 6 research nodes of 3 children's emergency departments, and a 7th node of 4 pre-hospital agencies. Additionally, about 4 or 5 years ago, Pitcairn added an additional EMS agency to each of the emergency department nodes. So from an EMS perspective, it is a collaborative effort of 10 EMS agencies, really nationally represented, that collaborate for pediatric pre-hospital research. It is a phenomenal opportunity to work with these wonderful researchers, all of whom have a single EMS scientific advisor, as well as an specific EMS researcher. So it's been phenomenal. And they were wonderful partners in this study. During the study, there was a changeover in the configuration of Pitcairn, so we actually had, I think we ended up with 11 agencies that participated, just simply because we had one outgoing agency that continued participation in several new agencies when the grant changed over. So yeah, it's been a phenomenal opportunity. It's wonderful.
And I don't think it can be emphasized enough how important that collaborative effort is, particularly when we're examining things that might be low frequency but high criticality, like encounters with pediatric patients. On a given day, any single EMS agency or any single unit may not encounter very many patients who need analgesia, but when we're able to pool the data together like this, we can study things in a much more efficient way.
I think also that one of the benefits of Pitcairn is that you really have a wide spectrum of EMS agencies that participate. So you have the large municipal agencies, suburban agencies, and some rural agencies to paint that picture of the pre-hospital experience of children.
Yep, that brings up that saying, if you've seen one EMS system, you've seen one EMS system. So having that variety and that natural variability provides more robust answers. And so speaking of answers, I am going to turn it over to Dr. Fernandez to talk just a little bit about the methodology of the study before we dive into the results.
Well, I'd want to start by thanking both of you again for joining us today. I think that your paper is not only really interesting, but really valuable in addition to the literature. So I'm really excited to talk about this today with you. So thank you. So let's go ahead and start. We talked about your objective, and we got a little bit into Pitcairn. I'd like to start with your study design, because I think this would be really informative for our audience. So this was it was a planned secondary analysis of a prospective multi-center cohort of children with actual or suspected injuries transported to one of 11 Pitcairn affiliated EDs from July 2019 to April 2020. I think I have an idea of why you ended the study in April 2020, but can you unpack a little bit of your study design for the folks? Again, a lot of our audience are kind of budding researchers, so if you can unpack some of the secondary analysis, I think that'd be helpful.
I can take a jab, and then Lauren, feel free to dive in. I think there's a couple of things that are important to note here. One is that the reason we included both confirmed and suspected injuries is because in the pre-hospital environment, you have someone who, fell off a ladder, got hit by a truck, and you suspect they've got, a femur fracture and might not be clinically determined until they get to the emergency department. And we know that EMS clinicians are working with the best available information to make their clinical decisions. In some respects, there was a bit of a convenience sample. We had our research coordinators working something like 2/3 of the academic day, like 18 hours a day in our 11 different sites. That in part is a facet of the parent study, which Lauren can speak to as well, which looks at the barriers that EMS providers reported in the provision of care, the decision to provide or not provide care. So this is really a planned secondary analysis of that primary study, but I think captured a broad spectrum of children, and ultimately for the primary study, EMS providers to paint that picture. Lauren?
Yeah, thanks, Matt. I think that you did a great job. I can speak a little bit more to the genesis of the study, and the importance of interviewing in real time the pre-hospital provider. Right? We had over 400 separate study encounters, which means we had probably at least 400 EMS providers who were willing to spend a few minutes after they completed their clinical care. And we all recognize that return to service time is really important, and how quickly you turn over for that next case is extremely important. And then we're very grateful that they were able to take a couple minutes to be interviewed by our research staff. And that was absolutely essential because, as Matt mentioned, that really the parent study was to better understand the barriers that are actually encountered by EMS providers as they make the decision, and sometimes it's a difficult decision of whether or not to provide analgesia to children with suspected or confirmed injuries. Previous literatures that have addressed the barrier, or previous literature that have addressed the barriers, have really been either survey-based or small group discussion. And so we've solicited the opinions of EMS providers, but in a really non-clinical format. And so it was really essential for us to have the EMS providers be able to tell us, with a specific patient in mind, immediately after they concluded clinical care, what the barriers they encountered. And then adding this secondary planned analysis was really simple, because all we needed to do then was to grab the outcome data from the emergency department. And so we had what the EMS providers told us they did, and now it was really fairly a simple process to link it to the emergency department chart, and then to review the chart for what the emergency department actually did, and to see then what the impact of those decisions the EMS providers made on these children.
It warms my heart to hear an author say that it was linking outcomes with pre-hospital data was the easy part. Things have changed, and it is so great to see. So let's talk a little bit about who was eligible for your study. So you looked at pediatric patients from about 1 month to 17 years, and it was anyone with an injury-related chief complaint, of course, transported to one of the Pitcairn sites. Can you tell us a little bit about any of the exclusions and how you came up with your inclusion-exclusion criteria for this study?
Sure. So, we certainly excluded those who were in cardiac arrest with the presumption that there were higher clinical priorities. We excluded pregnancy. We also purposely included only injuries, right? Because we know the subjective assessment of things like abdominal pain really, I think, introduces non-traumatic abdominal pain really introduces some of those other questions about, again, some of the myths in the pre-hospital setting about, hiding, appendicitis and other medically relevant causes of discomfort in children.
Yeah, no, that was great. And we talked a little bit about how you gathered some of these data. You had your research coordinators. They seems like they played a really big role. They were fantastic for you. Can you talk about some of the folks who are listening today are looking for ways to get involved in research and they're just starting out, and research coordinator might be a good stepping stone to get in that door. Can you talk about the role your research coordinators played and how they helped advance your study?
Sure. So, research coordinators, I think, have become an integral part of not just pre-hospital research, but really emergency department-based research in general. I can speak that at our institution in Colorado, at the time, I had a cohort of three students at that point who were pre-med, pre-nursing, pre-something in the health profession, who, to your point, Tony, were looking to get involved. And I think that becoming a research coordinator offers you not just an opportunity to get involved in the research, but to learn the infrastructure for good clinical research. And I think that, after a month of learning how to develop the manual, that guides our research care, you really get very deep into the weeds, not just of data abstraction, but also data analysis. And Lauren, you have a lot more longitudinal experience with the coordinators. Do you want to talk about your experience with them?
Yeah, our setup is fairly similar to Colorado's. Here in Milwaukee, we usually have 4 or 5 that are either full or part-time employment that manage really up to a dozen different studies in the emergency department at one time. They were invaluable in our study because this is how we collected the data. When we managed if you're going to do a prospective data collection, you have to have somebody who is there in real time to work the mechanisms to collect the data. And so at every institution, except one, there was one, Charlotte did not have research coordinators. They utilized the site principal investigator and the fellows that were in the pediatric emergency medicine fellows sacrificed their time to perform this work. And so having research coordinators really is valuable because it allows them to fill that gap of collecting the data. And it is a valuable experience for them. The primary research coordinator for this study is assigned all of the EMS research studies in the emergency department. And so now when we sit down to talk about an EMS study, he has a phenomenal wealth of knowledge of interacting with pre-hospital providers. He's never been one, but he has worked with them long enough now that he understands the ins and outs of doing high quality research in the pre-hospital setting.
And I should say it provides an opportunity for mentorship, right, Lauren, to really step in there and provide that education, right, to walk into these jobs. And also, I think from a data integrity perspective, we have the opportunity to interact with them and check every few charts to make sure that their data abstraction is appropriate and so forth. So I think there's a quality component to it. There's an educational component to it. So I think it's a great experience for those who would like to get involved.
Yeah, agreed. So back to your study, you compared pharmacological interventions to non-pharmacological interventions, and it often happens in many studies where you get in there and you realize you aren't able to, or to collect data that you initially would have liked to collect. There are barriers for some reason or other. And I believe that in this study, you were unable to collect the types of opioids and the specific types of non-pharmacological interventions. And this is very common in a lot of studies. And if you could just speak to the audience about kind of some of the barriers to collecting these data and how you you pressed on and were still able to produce a valuable study even without the perfect data set.
Yeah, so let me speak first because the questions are really my responsibility in this, and I'll answer them very honestly. The first regarding the type of opioid was actually very easy because all of the responding agencies really universally, no, I take that back, different study, sorry. We didn't, it really was short-sightedness on the study design on my part. We really had hoped, as far as the pharmacology and the non-pharmacology was concerned, that it would just kind of be binary and be yes, no. And then as we were getting ready to analyze our data and the numbers started to come back, we realized that there was a big hole, and this is one of the limitations, in that we couldn't define what a non-pharmacological intervention was. Right? We simply asked the EMS providers if they provided one. And it would have been a more powerful study and more helpful, especially to our basic level providers, if we could tell them how well individual non-pharmacologic interventions helped. But whether it was splinting or distraction or elevation or any of the other issues, that was deficient in our data. And so if I were to design it again, there would absolutely have been questions about what type of non-pharmacologic agents were used. It did not destroy the study, though. We are still able to comment completely on pharmacology versus non-pharmacologic interventions, which I think is a high-level view, but is valuable. And so I think every study has these points where you go, God, I wish I would have done that differently, or I wish I would have included that. As much as in hindsight, it seems like a simple ask that we should have realized, it's just one that we didn't. And so,
and I think there's a fine balance between the let's collect this data just in case and then overburdening your participants versus setting out to collect the data that you intended to. So this is completely natural part of the research process, and there's always going to be those things that, man, I wish I would have collected.
Yeah, and you didn't let it get away from you really producing some really valuable work. I think this is a great paper, so I commend you for that. Again, we talked earlier about how linking data for your paper was one of the easier parts. I'd love to hear that, but let's talk a little bit about how you did link those data. This was deterministic linkage, so essentially you were looking for exact matches on things like name, date of birth, chief complaints, and the like. Can you talk to us a little bit about, sometimes you can get into some, with deterministic linkage, you can get into some fuzzy areas with names, Bobs and Williams and those sorts of things. Were you able to account for that at all in your linkage process?
Yeah, so we left the process of the determination up to the individual sites because they knew their processes best. As you can imagine, there was an expectation, however, that the site principal investigator was responsible for adjudicating any concerns about not being able to find patients or those issues. As you can imagine, in real-time data collection, sometimes the errors get perpetuated, right? So the names get misspelled or the date of birth is off by a year, and we definitely saw that. I will tell you what I learned from this is the absolute most important variable was the date and time of arrival. And thankfully in the system we used, those were time-stamped, so there could not be a transcription error because the system automatically assigned those. And then if the other values were off by a different name, a different last name, a date of birth was incorrect, there usually was enough information around that date and time of arrival to find the patient that probabilistically seemed like the same patient. We also did it in real time where the EMS or as soon as the research coordinator was done, they would pull the medical record number from the emergency department data. And so we had that backup as well where and the linkage is not easy because we required somebody there to be there in real time, but because somebody was there in real time, it was simple to link from there. Much different than when you try to go back and look at charts retrospectively and try to determine who's who.
Thank you, and that's what I wanted to get out is the planned prospective part of this certainly helped with that linkage, and I think it was a well done part of your study. So when we talk about we'll get into starting to maneuver through the methods and get closer to our results here. So you grouped your pain severity scores into mild, which was about 0 to 3, moderate, which was 4 to 6, and severe, which is 7 to 10. And your primary outcome was comparing the difference in pre-hospital and ED pain scores between those who received an opioid, analgesia, or non-pharmacologic pain medication and those who did not. Do you have do you want to speak to the audience at all about how you came up with these categories and made these analyses?
I can touch on that because this was certainly a topic of conversation that Lauren and I shared many times, and I appreciate his guidance throughout all this. You know, the pain scale themselves, I think, are taken from sort of the most normative ones available in the literature. I do think there are some limitations in general with the use of this. That, you know, a moderate pain score from 4 to 7, there's likely a big difference between someone with a 4 and a 7. But we wanted to be consistent with prior reports, so that was really the driving force behind using those pain scale scores. In terms of the stratification of the groups themselves, you know, I think there are several approaches one can take, but here we're really trying to identify in large numbers what the impact was either of pre-hospital opioids in this case. I think we should be specific and not necessarily calling them pre-hospital pharmaceuticals, because we purposely, we did not include, for example, you know, in certain agencies now, for example, Toradol might be available. They were not available at the beginning of the study, or ketamine is another example. So it really is a dichotomous descriptor of either pre-hospital opioids or non-pharmacologic intervention. And eventually we decided to say there's a cohort of people who receive both. So we have to try to account for either opioids, non-pharmacologic interventions, or some combination thereof, and then identifying the impact of that care modality on those emergency department outcomes, primarily being the initial ED pain score, but then also in secondary analysis, how quickly did people receive that emergency department dose, and what dosage and what morphine equivalent, and also what was their outcome. Did they get admitted? Were they sent home? What was their length of stay in the emergency department? So we're really trying to broadly describe the impact of that pre-hospital pain strategy on the emergency department outcomes we selected.
Yeah, and I'm glad you brought up some of your other outcome measures. Before I open it up to our other panelists for any other methods questions before we get to your really interesting results, can you just, for anyone who's unfamiliar with how you develop these morphine equivalents, can you just speak to how that would be interpreted as we get to your results?
Lauren, do you want to address this, or I can?
Yeah, oh yeah, sure. So this is pharmacology that I didn't derive or come up with, but it turns out that almost all analgesia medication can be converted with straight multiplication into a standardized, basically the equivalency of morphine. So if you take a dose of morphine, the morphine equivalence for morphine is 1. And every other analgesic medication has a factor by which it can be multiplied to give you a morphine equivalent, so a comparison directly to morphine. So this was extremely valuable in the emergency department, where we had a host of different analgesics, from ibuprofen and Tylenol to fentanyl, morphine, and Dilaudid or hydromorphone, that obviously have a varying degree of impact on analgesia, but we could standardize it by bringing it all to morphine equivalents, regardless of the medication they received.
It's not so different in understanding for our paramedic colleagues here in comparing Ciamedrol and dexamethasone to standard hydrocortisone equivalents.
It's a good example.
Fantastic. Well, you'll hear from me again as we get to the discussion, but again, great work. Thank you very much for being with us today, and I'll open it up to our other panelists for any method-specific questions before we dive into those results.
Jeff.
Hello. First of all, just wanted to thank you again for coming and joining us today and sharing your terrific work. I just had a very simple and straightforward question about Pitcairn and study participants. So of course, we all know that if we're being watched, if we're being observed, we might behave a little bit differently than if we're not. I was wondering if these EMS agencies, they know that some of their data might be looked at later for research, but how kind of publicized was this study potentially at the time, since I know this was prospective, and there are these research coordinators that are talking to EMS clinicians. How might that have affected things? or were EMS providers not necessarily aware of this?
Yeah, that's a fantastic question, and I can describe the methods, and we can kind of make some suppositions about the impact. But we surveyed all EMS providers. Most of our agencies, and again, part of the reason that we used the sites that we did is because they partnered with a specific EMS agency to do research. However, our enrollment was not limited to that agency. So our enrollment setting was actually in the emergency department. And so any EMS, transport an EMS agency with an eligible child was eligible to complete the survey. So while I can only speak to Milwaukee, about 65% of our EMS traffic comes from our single Milwaukee County EMS. But that means 35% of the patients come by other municipalities or private ambulance services. And so while we did provide, at least in Milwaukee, provided study notification to as many of the agencies as possible, we don't have any way to know how much that filtered down to the individual level provider. We did not, and again, this is another limitation, we did not, however, track repeated measures. And so we don't know how many of our EMS providers were enrolled in the study or had an opportunity to bring in more than one eligible patient. We assume it was very low. Milwaukee County has over 1,000 providers. If you look at just the ALS providers who are more likely to transport these patients, it's over 500. And we enrolled 100 in Milwaukee. That's correct. We enrolled, I think it was 100 in Milwaukee. So we just by simple math, we would assume that repeated measures were very uncommon, but we did not track those data to be able to tell for sure.
Important point. Thank you. All right, I've got one more methods question, and it's really more of a comment that I want to highlight going into this because I think it's really important, and it was you all made what I feel is a really great choice, but I'd love you to talk about it. And that was the decision to include BLS only unit responses. So would one of you care to talk a little bit about that decision? Because some would say, hey, like BLS can't give pain meds, why include them? But let's talk about why include them.
Yeah, I could take a stab, Lauren, if that's okay.
Please.
First of all, I think that in a very similar fashion that Pitcairn affords us the opportunity to get exposed to differences in care geographically. In some systems, pain, trauma, even major trauma, is a BLS only call type. So to assume that, for example, in New York, where New York City, where I practice now, major trauma is a BLS call type. There are no opioids available unless they're requested, and I can tell you anecdotally that's really uncommon. And I think it paints the whole picture of EMS care. And I think there probably were anecdotally some examples here where ALS either intercepted or was called upon. We don't have that granular data by their BLS colleagues, but I think that painting the picture of what the BLS providers can do and have a meaningful impact potentially on the patient's pre-hospital pain score for sure, and potentially in the emergency department as well, I think was important.
Yeah, and I think that it's a deficiency in the literature to date is that we have limited this discussion to ALS level providers with good reason. But I think it provides an incomplete picture of the scope of injured children who are cared for by emergency medicine professionals.
Absolutely, and I think what you all did is a patient-centered approach. The patient falls and breaks their arm. They don't choose whether an ALS or a BLS unit responds, and so it's important to examine this in the face of inequities and who even had the opportunity to receive these medications. So I think that's an important part of this, and we'll definitely be talking about it as we hit the results. So without further ado, we'll be moving into the results now, and I will open it back to the other panelists as well as our audience. I see a couple of questions have come in already. Please keep them coming. But first, I'd like to hear from you all. If there were just a few things that the audience could take away, what were the main findings of this study that you all feel were really important? You're both smiling. I know you both.
Go ahead, Matt. I want you to take this one first.
Well, I think we both end up at the same place, but I think the nice part about this study is there's so much important data you can walk away from. I think on the positive note, I think there's a bit of a paradigm shift here. And Lauren, I try to steal this quote from you all the time, so please keep me honest here. I think what we showed, number one, is that in those people who received pre-hospital analgesia, they were overwhelmingly those who are at higher pain scores long bone fractures, et cetera. So the ability of EMS clinicians to identify those who most appropriately should receive a pre-hospital opioid, I think was reinforced that training and education that we hope our providers have. I think that was sort of further boosted by the fact that those who got pre-hospital opioids went on to get earlier doses of opioids in the emergency department and quicker, right? So if they were recognized as being severe in the pre-hospital setting, they were likely to be recognized as being severe in the emergency department setting. So I think it hopefully demystifies or debunks that myth of the potential lack of impact that your care may have once you get to the emergency department. To Lauren's point earlier on, you might only have a 7-minute transport, but if you're able to throw some intranasal fentanyl into that patient, number one, you'll help them feel better in the pre-hospital setting, but probably your recognition of that patient is very comparable in many respects to how we in the emergency department identify those patients as being in severe pain. I think that's one of the very positive messages to our EMS clinicians. That being said, I think there are two other messages that show where we have room to improve as EMS clinicians, right? One is that only 19% of 474 patients got pre-hospital opioids, and only 36% of those who had documented severe pain. And Ramley, I can kind of see you smirking when we talk about documenting pain scores. Only 77% had a documented pain score. So 1 in 4 children potentially who were very badly injured didn't have a pain score. And we know from prior literature by Lauren and others that if you don't document a pain score, you're very likely not going to intervene. But I do think that even looking at that 36% with severe pain, that means 2/3 of kids in severe pain did not get opioids in the pre-hospital setting. I think that's a gap. I think the other thing I'll point out, then I'll hand it off to Lauren, is that when you look at that moderate group, that 4 to 7 group, if you will, which again, I think is problematic just in all of EMS literature, because I think that moderate group, really the 7s are, I think, a little closer to 8 and 4 maybe a little closer to 3. Only 8% of kids in moderate pain received pre-hospital opioids. So are we potentially under-treating kids on the higher portion of that moderate spectrum? I think is an opportunity for improvement. But those are my primary data takeaways.
Thanks, Matt. And I feel in some ways, and it was inadvertent, I'll tell you, that these data kind of throw this discussion a little bit on its head. And let me explain why. I have a very good scientific advisor who contributed to the design of this study. And when I floated out my hypothesis that basically was going to say the earlier we treat pain, the better we manage it, the less they will need pain management interventions in the emergency department. That was my prevailing hypothesis when we designed the study. And he looked at me and he said, I think you're going to be wrong. And I said, really? And he goes, yes, I think you'll find that the patients who get treated in the pre-hospital setting are the more severely injured who will have higher ongoing pain needs in the emergency department. He was exactly correct. And so we learned that the recognition of pain by an EMS provider is actually pretty comparable to the recognition of pain by an EM provider. And I think if you review the pain literature for pre-hospital providers, we've given them, and we meaning the researchers, give them a little bit of a bad rap. Treat first what kills first. Pain's not important. They're going to get treated in the emergency department. We have come up with all these explanations on why we undertreat pain in the pre-hospital setting. But as it turns out, those children who really needed to get pain management received it at about comparable rates as they did in the emergency department. And so I think we hopefully show that the EMS provider is better at this than we've previously discussed. And then it makes a difference, right? You really basically took a population of patients that were treated with opioids in the pre-hospital setting that had higher pain scores, and you brought them down to a level of pain severity that was equivalent to everybody else at emergency department arrival. So there was a very clear impact and effect of treating pain in the pre-hospital setting.
And I shared that initial hypothesis. I would have guessed as well that if we treat pain early in the pre-hospital setting, we're more likely to get a hold of it early and preclude the need for further treatment. And I thought that those findings were really interesting and also really important. Both of you mentioned pain assessment and how important that is. And something we've seen in other work is that, we use this cutoff of less than 18 for pediatric patients, but it turns out that there's a lot of difference within groups of pediatric patients. And so I was wondering if one of you would be able to comment a little on how pain assessment and probably analgesia administration changed within the younger pain categories, or younger patient age categories.
I'm gonna have to think about this one for a second, Matt. Do you have anything off the top of your head?
Yeah, I think that I don't have I'll have to probably come back to you, Remley, with some more specifics in the data, but I think we know that the literature shows that the younger you are, the less likely you are to get, prehospital pain management in general, and certainly prehospital opioids. I think historically a lot of that had to do with the number one, sort of three myths, right, that we try to dispel. One is that the route of administration was a barrier prior to intranasal fentanyl and other intranasal opportunities, that just getting IV access itself is painful to children, and why am I as a provider going to put the child through unnecessary pain just to hopefully make a dent in their pain? I think there's a discomfort level. We know that certainly with vital signs, you're much less likely to take vital signs if the child is getting closer to zero. So I think those probably play in together. But again, I think for us, one of the highlights here is that, it was only 3/4 of people who had a documented pain score. And I think that's a very, very notable gap, because once again, I think if you don't document it, you won't treat it. But I suspect that, I'll have to come back to you with the specific numbers, but I suspect that the documentation probably skewed off as you got to younger ages. But I'd have to come back to you with that data.
Yeah, that would be my guess on that as well. And the only reason I say that is, maybe it's been a while since I was in EMT school, but for me, I was taught the 1 to 10 or the FACES pain scale. But what do I do when a child can't talk and I can't say, well, which face are you? You look like you're in pain, maybe, but I can't get you to self-report. And so I wonder if either of you could comment a little bit on the use of observational pain scales in the ED and whether or not you've seen those kind of move their way into the pre-hospital setting.
Yeah, I think they're quickly becoming and should be the standard of care, and of training and expectations for children that are either nonverbal or pre-verbal. I spent the last year thinking about how we assess pain and how we document pain and how we actually tell how much pain somebody is feeling. And we all know that there are limitations in the pain scales, even when used with an adult with good numeracy skills, right? And I'm sure you've been in the doctor's office with painful complaints, and you're like, is this a 6 or a 7? I'm not quite sure, right? And people, even thinking and intelligent adults, have a hard time with that question. And so there are inherent limitations. The observational pain scales in that regard are a little bit better because it removes that subjectivity. Where it introduces complication or issues is that not everything that makes a child look upset is pain. And so sometimes you don't know if your observation pain scale is actually assessing pain, or is it assessing anxiety, or is it assessing fear, right? There are some overlaps between the observable physical cues that we look for on the observational pain scales. So I think they're absolutely invaluable, but they share some of the inherent limitations that an objective pain scale, that all objective pain scales have.
Oh, absolutely. And for
Right.
those
Roman, I was going to add just quickly that I think that part and parcel of this discussion, though, is that if the idea is that documenting a pain score may lead you to intervene, it also requires you to reassess the pain score, right? Because I think that's one of the things that we know, is sort of a foundational aspect of prehospital medicine, right? If you intervene, you should reassess. We certainly didn't document that here, but I imagine if a primary assessment of pain scores at 75%, I'd venture good money that the reassessment scores were probably relatively low.
And that is a critical point. Even if the transport time is short, having that reassessment is key. And for those who aren't familiar with these observational skills that we're mentioning and might want to go look up some more information on these later, Lisa mentioned one in the chat, FLAC. I think CHIOPS is another one that's becoming more popular as well. And there may be others, but that is something important for us to start incorporating into pre-hospital practice as well. And now I'm going to open up, we are nearing the end of this hour. Time does fly when you're having fun, but I'm going to open up to our other panelists, and I'm going to take questions from the audience as well. One interesting question from Lisa surrounds the idea of, we talked a little bit about dosing, and so her question has to do with the weights. Basically, were you able to compare the weights used by EMS for the dosing versus any of the weights perhaps obtained or estimated in the ED? and any insight on to correct dosing?
That's a great question. I don't believe we collected that data. Lauren, you can correct me if I'm wrong.
Yeah.
But I think it's an important question. I think it dictates how, certainly in pediatric pre-hospital pain management, how we dose patients, right? Because it's not a standardized dosing as you might expect to see with your adult patients. I think comparably, in the same vein, we don't have necessarily, we can't really comment on the inter-rater reliability between the ED providers and the paramedics, right? Because I think there's the dosing component, and then there's the pain assessment, that visual pain consideration. But no, I don't believe we can comment directly on the weight between the two patients, between the two locations.
No, but it would have been nice to have had Lisa on our study design team, because we actually tried. As we were in the middle of data collection, it was suggested that we didn't have, and this is true, any way to assess whether or not the dose provided by the EMS provider was appropriate because we lacked a weight. So at that point, we amended the study to be able to go back into and retrospectively look at the EMS record to see if we could discern those data. And unfortunately, the weight was so poorly represented in a retrospective in the chart itself that we were unable to comment. So we did try, and if Lisa had been on part of our study team at the beginning, it would have been one of the questions we asked the EMS providers.
Next time.
Yeah, definitely. That's a great one. I mean, and that you just spoke to a really critical point. Our documentation in the field as EMS clinicians matters, and we might think it's not really that important to document a weight, but that would have been really useful for that aspect of the study. All right, Jeff, it looks like you have a question.
Yeah, thank you. So I have a question while we're looking at table 1 here. There's a lot of really good information on here. And one thing that I was interested in particular is I noticed that you collected information on patient race and patient ethnicity. And we know increasingly that unfortunately there are really big gaps, really big disparities when it comes to emergency department and adult pre-hospital pain management in racial and ethnic minorities. But I know there's not as much literature when it comes to pediatric pre-hospital pain management. I did some very rough calculations and saw that there are some trends that still, unfortunately, there are some disparities where racial and ethnic minorities are less likely to receive analgesia. I was curious your thoughts on this. Is there any more investigation that's coming, and anything that you think about these disparities that we really need to address clearly?
Yeah, I mean, so I think it's an important question. Certainly I think that the care we see reflected in the pre-hospital community likely is reflective of the care that we see in the emergency department, and those disparities exist. I think it's such an important question that we have another manuscript submitted at this point that addresses in greater detail, just because of the gravity of this question and the impact it has, not just on care, but sort of the societal impact of pain management in children. So I think there's some of that data will be forthcoming in an upcoming manuscript, because I think we really want to be able to dive into those answers with a degree of granularity that it's hard to do right now.
It's actually kind of fun to leave a research podcast with the teaser. But yeah, there is a manuscript that's under consideration in a journal, and as soon as it's accepted, then we will be able to disseminate the information. So stay tuned.
You just have to have
We'll have you back in a couple months. As long as reviewer number 2 acts accordingly. No, I think that's critical work. And I love that, it got its own paper dedicated to it, because that's something I've talked a lot about in other analyses among adults, where it's really hard to control for all of the possible what ifs or all of those confounding variables. And so having that isolated into its own research question is certainly a good decision. Dr. Fernandez and I have also done some work in this area looking at analgesia for children with long bone fractures, and we're seeing similar patterns, but that is also in the stay tuned mode for more research to come in this important area. And so thank you for that question, Jeff, really good one. Now we are leaving into the last couple of minutes of this podcast, and I want to give you, the authors, a chance to leave us with anything that you think we need to keep in mind as we head out into the world and head out thinking about future investigations before I close us up. And so some of those thoughts may center around the barriers or that gap that needs addressed, or anything else that you think we need to know. So Matt, I will start with you.
Well, I think for the audience of EMS clinicians here, I think number one, you know, while many of us in research come out of an EMS background or dove into EMS as part of our clinical careers, you're on the road there, right? And I think that many, I think of the future drivers of the EMS research are going to come from you. And I think looking at current practices and barriers to current practices, you know, I think that's going to drive the future of EMS research. I think that as a very novice researcher here, I think one of the take-home things that I have taken from this study is that what you do in the pre-hospital setting matters, right? I think that there's, especially when it comes to a vulnerable population of children who are injured and all the challenges we talked about in their assessment, the provision of analgesia, the reassessment, their delivery to a children's hospital or to the local emergency department. And I'd even advocate a step further that in really focusing on your care of children in the pre-hospital setting, we looked at kids who are going to large tertiary children's hospitals for the most part, where we expect the providers will be able to recognize and treat pain appropriately. I think there are similar challenges in the community setting that I think if you take that leap and say, I am confident in my assessment skills, I've recognized this injury, I'm going to treat their pain appropriately, recognize that you may change the course of this child's care over the next several hours, and just how impactful that is.
Absolutely.
Yeah, and I would echo what Matt says, and I think that one thing that I've learned from this study, apart from the specific results, and I'll mention those in just a second, is the importance of looking at the EMS professional's role in the continuum of emergency care. So much of previous EMS literature and EMS literature or research that I've done looks at, it's a dichotomous, did you do this, did you do that? And we've looked at whether or not things were performed appropriately or adequately or however, whatever qualifier you use to describe it. But really the important question is, what was the impact of the outcome on the child's care? And I think we have, by disconnecting the pre-hospital from the emergency and surgical care the child ultimately receives, we've limited the scope of the important role the EMS provider plays. The first emergency responder, the first emergency provider who touches this patient, almost as in 9 times out of 10 is going to be an EMS provider, and it is the opportunity to appropriately assess, diagnose, and to provide appropriate management decisions that will impact the emergency care for the next several hours and even into their hospital stay. And so I'm hoping that this is the way research goes, that we, as hard as linking to outcomes can be, it really is what tells us where the changes need to be made, and really is a more accurate depiction of your impact in the pre-hospital setting, as opposed to just looking at whether or not something was done.
Thank you. And I also hope that this is where research goes. This was a powerful study with a lot of real world practical implications. And I just want to take a moment to thank you both again for generously sharing your time with us and allowing us to ask and answer some important questions around this work. And we really look forward to reading your next studies as well.
Thanks for having us.
Thank you. Yeah, thank you. This has been wonderful.
Sadly, our hour has come to an end, so I am going to have to carry us out now. And I do want to remind everyone that we will be back here with the Education Research Journal Club podcast on Friday, December 24th. And we will be back here with our clinical podcast next year, second Monday of the month, January 10th. So thank everyone again for listening and for your participation. Look forward to nerding out with you all next time.